literally.
And how do you biomechanically assess people then, apart from actually doing treatment? Because the issue, well, one of the things I'm seeing is that obviously there's a pain-related drive for people to come and get fixed, which it often is in lots of practices that treat all sorts of musculoskeletal problems. And so then how do you contextualize the heel or other part that's inflamed or sore or foot or hip within the framework of them as a patient, as a whole entity, holistically, one might say?
Yeah, so if we go back to, let's pick on Achilles and plantar fascia again, because that's probably the most interesting biomechanical area where the research has really changed over the last 5-10 years. So we go back 15 years, it was all about they're pronating too much, they need these shoes, this orthotic, and that. And then we realised that wasn't as simple, a bit like, core stability for low back pain, we realised that wasn't as simple as that either. And so if you looked at the research for whether a tendon is grumpy or the plantar fascia is grumpy or not, and compare those two groups, there would be very little to back up a biomechanical process or biomechanical predisposition to that becoming a problem. It's really just load. It's just you've loaded the tissue too quickly by too much. That is much more the evidence, rather than they've got too much pronation here, or their knees in valgus too much, or whatever else. Or, for instance, pelvis is doing something it shouldn't, okay? But it's really about they've loaded it too much. When you go through the case history and you start to learn about tendons, you pick out those parts where they've just suddenly done couch to 5K, but they've raced through the last stage, and their Achilles is just...
So their training program is suspect?
Yeah, they've done too much in too short a time, or they're doing the same amount, but their health has deteriorated. Either way, it's overload to the tissues.
So there is a holistic context in terms of that whole person.
Yeah, there's still a good portion of my brain that's, going back to those physiology days at university, that says, your tissues are just, I say tissues several times in the room. I try and take them out of the idea that it's a tendon, your tissues are just being overloaded.
So how would the state of health of someone, let's talk about that for a minute, affect the outcome or the likelihood of the improvement from having shockwave therapy? I mean, is there a type of patient? I mean, to choose your type of patient, what would be your ideal?
We're getting there with that, but simply because, I see them as a tendon disorder problem, and now the evidence is that if they've got some underlying metabolic disease, diabetes, thyroid, that sort of thing, that's a big predisposition for these diseases, and not allowing them to get better in a normal time frame. We've got data on smoking, we've got data on obesity. Now we're starting to get data on where the fat is on the abdomen. So you carry more white fat here, that's more inflammatory. That is not going to allow tendons to get better very, very well. In lots of the tendinopathies, it's female slightly more than male. And then the big one with females now, there's lots more evidence coming about perimenopause and estrogen's effect on collagen, and whether you turn over the tendon, get it healing in an appropriate way, lay down the right collagen, is somewhat dependent on your hormonal balance, which is why we think women get it more than men.
Right, so they were going back to shockwave for those cases where there's a metabolic issue, rather than a biomechanical issue, perhaps, or a bit of the two. So what's the sort of the way of approaching that with shockwave in terms of...
I always just, sorry to caveat that, it's always shockwave within, right? So I spend a long time on a whiteboard in my room talking about all of those health issues.
With the patient?
Yeah, which they can change and they should change. And I will often say, look, if you don't change these things, it might be 6-8 treatments and it's going to cost you this much. But if you could do take these changes in your life and, lose a bit of weight here, do this with your blood sugars, and perhaps have a chat with your GP about your hormonal health, because you've told me that you're getting hot flushes, and your memory's a little lost at the moment, and so on and so forth. You got, perhaps you need to touch base with your doctor about your HRT or whether you're having any or not, because all of that will support the outcomes for my intervention, which will be graded loading programs, getting you back exercising, and shockwave. Because I'd rather shockwave a nice healthy bit of tissue, because part of what it does is this regenerative effect. It's giving everything a stimulation and going, right, come on.
So is it less likely to be effective on a I'll call it degenerative, but on tissues that are not running optimally?
Same with our hands. I'd rather tackle some tissues that get a good red response, and they're healthy, and I know that's embedded within someone with a good cardiovascular system, good lymphatic drainage, all that sort of stuff. That's the same as shockwave. I use shockwave as an extension of my fingers. It does a few funky things, but it's a mechanotransductive input into the body that says to the body's tissues, would you mind just crack on? And I use my hands for that, but I used to. But shockwave is just a little bit more impactful and has a few extras on top.